This is the Situation Room, the only way to start your day.
I know it's still not looking pretty. We'll go into the details of some of that and just to understand. Okay, we should have at the very least been able to come out of this, but just not yet. And we'll talk about those details. But before we do that, Dennis has been taking us to Angola,
the seventh largest country in the continent, twice the size of France, rich in gold, diamond, and oil. They also have baobab, which continues to determine how the country looks like, especially when you're flying into Angola. But when you visit Angola, be sure where you're stepping on. Why? Because after this civil war in the country, there's a lot of live landmine that was left behind. The country's trying to detonate everything to make sure that it's safe for the people. So next time you visit, just be sure. Edoka kwa hoteli, mwende kwa beach. But let's go to the proverb, right? To walk alone is almost not to walk. To sing alone is almost to murmur. What do they mean?
I think what that means to me is, of course, when you come together, as when you coalesce your efforts, your vision, your focus, you achieve more. I think it resonates very well with me. Because that is basically what union is. Union is very many feeble voices coming together to generate one very strong voice that cannot be ignored.
Indeed.
Well said. Yeah.
At the very bottom of it, for sure.
Yeah.
And coming together to push for a particular agenda. In the last couple of weeks, we know that clinical officers have been on strike. We know that there is support that has come from the wider medical fraternity. And we know that other medical workers are also up in arms over so many things. Yeah. And it doesn't build a good picture for the state of healthcare in the country if the very people who are the ones who then transfer this care to Kenya's sick, then it doesn't look too good. We've also heard interesting words flying around that you people are just being stubborn. You don't want to listen to what the government is telling you. We've told you we don't have the money right now to then be able to deal with some of these things, but you've decided to put the health of many Kenyans at risk by not going to work. How do you feel about that?
Thank you, Ndu. And thank you, Aset. And thanks for what you do. You know, as I was coming here, I was really enjoying that other show that you're having. I almost gave up my mind so that I could continue listening to that one. But of course, thanks for having me here. And maybe before even I answer that, you know, it was very interesting from those guys. And I say that because that is how they like referring to people. Those guys.
Those guys.
And, you know, I was thinking, 5 billion you are giving to individuals. We were told 25,000. And then you look at, on the other side, you look at Makueni County. During Kivutha Kibwana's time, there are some factories that were built there. Yep. And I Googled just now. I don't know if my figures are correct, but I saw that one costed around 250 million, another one around 230 million. And I was just doing my maths. How many factories would we build with 5 billion? 20. If it was to cost 250 million. And I was wondering, from where I come from in Maunaro, Kunjoro, we are horticultural farmers and we have a lot of cattle and we produce a lot of milk. What if we built one canning factory for the horticulture and another one for the milk, a milk processing plant? How many youths would we employ there? Vis-a-vis, if we were to give them 25,000, what are they going to do with it? And which one would give better? But anyway.
That's interesting that you say that. Okay.
Because if you employ them, you could give them that 25 or 50,000.
And you're selling the product.
Month. Yes.
And you're selling the product.
Yeah.
Isn't it?
And you're empowering farmers.
Yeah.
There is a whole chain of transporters. Then once you have a finished product, you have retailers. it's a whole ecosystem that you're building. It is going to multiply whatever you have put in there. And with time, you are going to employ so many. But I don't want to digress outside the topic.
I do want you to. I do want you to digress.
Yes.
Because it is connected.
Yes.
We don't tend to imagine how connected it is.
Yes.
But so I need you to say that again, just so that we can be very clear.
Yes.
Because we're talking about the state of healthcare. The reason why we find ourselves in this position, Peterson, is largely government is saying not because they don't feel like clinical officers should have more money.
Yeah.
They don't. It's not that they don't feel like you're doing your job. What's the one reason that you've been given as to why you cannot meet the demands? They don't have enough money. True, false?
That is true.
That's the case, right?
Yeah,
we don't have enough money.
Yes.
And we know that one of the surefire ways of a government to then be able to have money to operate is two. It's taxes, or it's then manufacturing industry, so that you're not operating at profit.
Yes.
That's why I need you to say what you said again. We're talking
Very
about
good.
a fund, 50 billion, 50, what did you say?
5 billion.
5 billion shillings, which is the money that is being given out essentially for the
Empowerment. program,
empowerment.
Nyota.
Please go ahead.
Yes.
Say it again.
And I want to connect to health. Yes. So that is where I was actually coming.
Yeah.
If you give me 25,000, and let's say I'm brilliant, I may start a small business. I can start a kiosk and start selling a few things. Probably the tax I'll pay is VAT and maybe a business license that I'll be paying per year. But on the other side, if we could take this money and build the factories, the tax net expands. We have farmers who are now encouraging and are producing more milk because they have a market for it. You have finished product from this factory that we are selling. We are getting the value-added tax. We have transporters who are transporting. They are renewing licenses. They are paying for insurance. They are buying fuel. They are paying tax. You have retailers on the other side. And all these people, what you are doing, you're empowering them so that now they no longer be indigent. They will not have to be paid for social health authority, for the shift. Now they'll be in that bracket where you can now take their 2.75%. We can put it now in SHA, and we will not have to start saying that some facilities are rogue, wengine ni wezi, so that we don't pay them because we don't have enough money. We will start now paying back facilities and they'll be able to work. So it's actually connected to health because when you empower people, you empower them and they can be able to procure that health insurance. And of course, that becomes better for the country because now they can be able to get better health services. They will not stay at home. They will work. They will develop the economy.
Let me make it even sweeter. Let me make it even sweeter just to top up on that. When you make a good business environment and make it easier for entrepreneurs to start their businesses, when you make it easier for investors to come in, what you're doing is investors will set up their businesses, employment opportunities will get there, the 2.75% that you're talking about will be paid to the government. The entrepreneurs who are there employing 1, 2, 3 people will as well pay taxes that will end up getting into the kitty, and with that, the fund that we're talking about will grow, and the healthcare system in the country will stand. But even as we talk about that, it's just a proposition. You know, if they listen to us, we've given you a way out. We are not asking to be paid. It is just information donated. But let's talk about where we find ourselves with the healthcare system where clinical workers are on the street. This is not a CBA 2025. It is something that dates back years back, right? And one asks the question, what's the difficulty in just doing it right? One would say it is because we are focused on how we will get back to power and not focused on how we will treat the sick and the most vulnerable in the society. I don't know.
Very true. And there are some very difficult questions we need to ask ourselves as a country. In 2010, we gave ourselves a constitution. In that constitution and Article 43, we gave ourselves a very good aspiration that each and every one of us has a fundamental right that cannot be limited to access the highest attainable standards of health. But even as we did that, we then brought in a paradigm shift where we devolved our healthcare and changed the management from centrally managed to being managed under counties. We're having 48 centers of management of health. It has been 15 years. Have we done an audit? I think we need to do an audit. We need to ask ourselves questions. And whenever we ask this question, the governors and the other people in the devolution space, they think that we are asking for health to be brought back. That is not what we are saying. We must be very clear. What we are saying is, any system, whenever you change any system, you must have an audit. At least 3 to 5 years, you must have an audit. But now it has been 15 years and we have not had an audit. So we need to sit down and ask ourselves, is it working with the human resource? Is it working with essential supplies? We look at the 6 components that make a good health system and ask ourselves, is it working or not? If it's not working, then we also ask ourselves, what do we need to do? Can we be able to rectify whatever is not working within this kind of management system? Or do we then need to rethink how we are managing health and take it back? And this is what we try to propose when we are saying, let's have a central management of the human resource. Can we be able to look at how, instead of sending money to the counties and facilities, how we can be able to, instead, that money goes direct to KEMSA, and KEMSA supplies those hospitals and ensures that it is always supplied, because the workers are paid by the government, whichever, whether national or the county. The infrastructure is built by the county or the national government in terms of level 6. So if instead of taking this money back to these facilities, we would just send equipment and essential supplies, so that it's not a business. It is not a business arrangement. You see many patients, we give you more money, and then you decide what to do with it. This public is not private. We are not giving you money to develop yourself. We want patients to get the services, so that it doesn't matter which facility produces more money. What matters is, can we get enough to supply everywhere, so that even that facility that may not be generating a lot using SHA can then get enough medicines and people will not have to go there and lack services. The other day, we went across Nairobi and we ended up at Mama Lucy. We were stopped by the patients at the gates, and I think your colleagues were there, and they actually recorded some of it. And they were giving us their frustrations. We had gone there to check how it's going, and because Nairobi is on strike and all the health workers are there. But it ended up being the common mwananchi giving us their frustration with health, where actually ourselves we are also very frustrated, and we were there to so that we can try and amplify. And so there is something that is not working. And what is not working is leadership and governance, because anything rises or falls on leadership. It is the leadership that must then ensure that they provide the budget that is needed. But now, coming to answer your question, where we stand today, and I continue saying this, Ministry of Health cannot explain why we are on strike, because the approvals are there. It is only that the CS and the PS have refused to still append a signature.
Which PS?
That is, it's supposed to be CS Duale, signed by CS Duale and the 2 PSs.
Both PSs?
Both PSs.
Okay.
At the level of the Council of Governors, also, the approvals were given. But at least we had a meeting yesterday. I must acknowledge that. And the meetings are ongoing. We hope we'll be able to get a solution. But we have really subjected Kenyans to pain and disruption for practically no reason other than we have people in office who do not want to work.
I don't understand. Whatever has been requested by the union,
yes,
essentially has been approved by the ministry.
So, at first, the ministry had given us a a risk allowance of 15,000.
Okay.
Then they said later
Across.
the county government said, no, we cannot afford this.
Okay.
So we have actually made a lot of compromises. And after making the compromises, then we agreed and SRC gave the approval. The approval for the ministry came in August. And we concluded the CBA for the ministry in August and even initialized that now we have concluded this is the final document. We are just waiting for signatures. August of 2025. Since then, it has not been signed. On the side of the county governments, the final approval came on 22nd day of December. And it was done on 20th, about 3 days before we went on strike. Instead of them calling us to the table, because that was the only thing that was pending on the CBA, and we would have signed and concluded this matter, they rushed to court on that 23rd when we were to go on strike. And thank God, the court did not hear them. They were not given the orders. And the case was not certified urgent. And do you know why? Because the same court they were running to had directed them to have concluded those issues by October of 2024. And they didn't. And now they were running back to tell them, can you please force these guys back to work so that we can continue exploiting them? And I really must thank the courts because they didn't allow them to do that. So that's why I'm saying we really need a very difficult conversation about health, how we fund it, how we govern it, whether we are doing it right, because health must be a concern of every Kenyan. Many of us, you are just one sick relative away from poverty. And I know that better because I have been there. I know that better.
You see, if you look at the health system, since devolution, every other time there is, I remember the 2017 CBA that was there. It has been pushed. Implementation is a problem. You come forward, another CBA is signed to amend the 2017 CBA. Still a problem in implementing it. Now we are at a position where the court has spoken and said, guys, do this. We have agreed on everything, but just appending a signature on what has been agreed upon is a problem. Many say, watu vichongumu hamtaki kusaidia wananchi. But here's a question where wananchi themselves are also saying, Agai, even with health workers here, we are unable to get the services we need because hakuna madawa, there is no equipment and everything else. In total sum, you look at the health system, like you say, there is need to relook on how we are managing healthcare in the system. There are many who say we need a health commission that will help us manage everything all together. Is that the direction we should take? Is there goodwill in finally dealing with the problems in the health system once and for all? And if someone somewhere sees this as not a priority, then what is our priority?
Yeah, and I think it goes even beyond the conversation about the Health Service Commission, because let me lay the ground.
Yes.
You have a health sector that has an aspiration in the Constitution, the highest attainable. Do you know what that means? It means that every year we should see us improving on our services towards somewhere. And Vision 2030 documents it very well. I wish people can read Vision 2030 on health. Then you come to the other side and you find that the PFM Act tells you that 35% is your ceiling on recurrent budget. And when you go to the counties, because the 35% is regarding to the amount of money you have, the budget you have under the county. So most of them will have exited. On the other side, you go to the documents of the Ministry of Health, and you find a very good study that was done by CS Nakumicha about preparedness for UHC. It was very good, by the way. And it brought out the real scenario that we have a dire shortage that cannot even guarantee accessibility to health to Kenyans to set off UHC, and recommends that, like in the case of clinical officers, we should employ almost 18,000 more, because we are supposed to be 24,000.
And you're currently only 6. Okay.
You're currently only 6,000. Okay. So that is the ministry. This is the PFM Act. On the other side, there is the budget under the county. So you, even if you get some small amount of money you want to employ, then on the other side, the controller of budget is saying, hey, PFM Act, you have already exceeded 35. Then you find that whenever we are having a conversation, like now, one of the issues that has been in dispute has been payment of statutory deduction, has been the issue of career guideline. So whenever there is something to improve on the payslip of a health worker, not only a health worker, let me just say workers under the county, it becomes a problem because they are saying we don't have money, PFM Act on the other side. So we live in the same country, but we have very conflicting laws and policies. This one wants more health workers. This one says, no, you have exceeded your ceiling for recurrent. The other one says, but patients are dying in the hospitals because we don't have enough health workers. So when we are calling for audit, we are also saying, can we look at the entire environment? Do we need to separate health workers from the recurrent budget into development budget? Is health a recurrent expenditure, or is health a contributor, a central pillar of socioeconomic development, so that we stop looking at it as recurrent? We need to look at that, and which laws then do we need to look at so that we can tweak? And that is where the conversation for Health Service Commission came from. It was not purely about being under the counties. It was also, how can we then go above this PFM Act so that we can have a body that is not subject. When they are given the money, the entire amount is for hiring, and so the recurrent maybe will be the administrative fees. And if then you separate that, we were seeing that probably now the counties will have enough space and money to be able to stock drugs, to be able to provide essential supplies, to be able to provide equipment. So that is where the conversation is. And what we have been saying, if we can sit on a round table and we are told that, okay, we get the principle, we get the objective. The Health Service Commission is not the solution. Yeah. This other thing is the solution that will be able to sort this. We are very open to that conversation. But what we are trying to say is that something is wrong. We need to find out why it's wrong, and we need to come up with a solution. As we sit here, we have around 94 health workers, laboratory officers and clinical officers. They were employed in this country around 2009 when HIV was really ravaging our people. Realizing that TB was the opportunistic disease that was killing Kenyans who had HIV, they were employed specifically to deal with TB, and especially within HIV. Then, when Global Fund employed them, they entered into an agreement with the Treasury that we are providing this money for this duration. The moment we are withdrawing, then you will provide this money to absorb these people so that they can continue working for Kenyans. Time comes, a Global Fund exits, Treasury does not provide the money, the ministry says, okay, we will only employ the ones who are at the national government level, though they are the ones who had given them contracts. They leave the others who are working under the county facilities, and for 20 months they have not been paid. 20 months. You go to the ministry, they tell you the problem is the county. But we tell them, but the county has never given them a contract. You are the one who gave them a contract. You go to the counties and they tell you, hey, these people are not ours. They have never been transitioned. How is it our responsibility? So that is one of the outstanding issues, and that is why we were unable to agree, especially at the county council of governors, together with UHC, because you are saying we cannot have officers where they are not owned by the ministry, they are not owned by the county governments, yet they are serving Kenyans and they are suffering. But there are people in office who actually know this.
But their names are their names not on a list somewhere, on a payroll somewhere, these individuals?
The contracts are with the national government. The government knows them.
So I'm wondering, how do you now say you don't know who they are?
Yes.
They say that it is the county governments. And that is why we have said, on the issue of the UHC and the Global Fund, because essentially we are now agreeing on the issue of risk allowance. But on the issue of the UHC and Global Fund, we have said we must have a sitting where the Ministry of Health, the Treasury, and the Council of Governors are on the table so that we agree who takes responsibility for these arrears, who takes responsibility for this gratuity, and who takes responsibility for now giving permanent and pensionable terms to ensure that these people continue serving. The other thing that we are fighting for, and it's good that Kenyans understand, and I have said this multiple times, and I'll continue saying, I know many a times when I say it, people think that I'm not being sensitive. But many Kenyans, and it's good we talk about the issue of these, what do we call them, quacks.
Yeah.
Like, you know, the case of Kawangware, the one who extracted a tooth and somebody ended up dying.
Yes.
And maybe even before I make my point, I need to advise Kenyans that anything to do with your mouth and your throat is a very dangerous scenario. It goes directly to your heart. There is a condition called rheumatic fever, and usually later complicates into rheumatic heart disease. Talk to cardiologist. And understand how many Kenyans are suffering. They have to go through open heart surgeries just because a pharyngitis, a sore throat was missed when they were young. Just because a tooth was extracted and they were not in an antiseptic environment or a sterile environment, and they got an infection that then went to heart, injured their valves, and by the time they are getting to their 30s, for ladies, the time they are getting pregnant, that is when they realize they have a cardiac disease. Some of them die. Some of them spend at least 6 or more months in hospitals because once you are pregnant, when you have the rheumatic heart disease affecting the valves, you have to stay in that hospital until you deliver. And some do not even get to that point, are not that successful. So what I'm trying to say is that there are things that we take very simply, but the consequences that you get later are very dire. Sometimes they cost life. So why is it that we are having the quacks in the system? We have a system where we have health workers who have been trained. We have a government that is not deploying them, employing them and deploying them to the facilities. So you have, I saw another story of a clinic officer who has been attacked. I have seen many doctors, some have even sold to me clothes online. Doctors, somebody went to school for 6 years. A clinic officer went and did their BSc for 5 years. A nurse went to school for 4 years. Then they come out and they're selling clothes out here to make a living. Yet there is a patient dying in hospital because they cannot get that service. Then you have a government in between that is supposed to employ these people, and that in 2013 went to Brazil and the WHO conference on human resources, and the CS was representing the country, signed a commitment that we as a country, we appreciate that we have shortage of health workers, and the solution to this is that each and every year we will be budgeting and employing 12,000 health workers. But that has not been done. So when you have that unmet need, when you have that gap, that is where the quacks come in. And the quacks will be there for as long as we do not have enough health workers.
You know, Peterson, when you talk about healthcare, the other day we were having a discussion here by member union KMPDU, and we're being told if the government today decided to employ all the health workers that are there, that are employed, there would still not be enough to serve Kenyans because they are few in number. You know what I mean?
Yeah.
And with that just in mind, and you look at how Kenyans remain being exposed, healthcare, education, and everything else that is, one would say, is basic but very critical for any nation, should be top of the agenda, should be the biggest vote head, whichever you want to look at it. But we do not want to do that. And Kenyans continue to die. Services still are not being delivered. Does anyone can do?
There was something we talked about earlier this morning, and maybe I can connect to that answer. Is that thought to myself, you know what? First of all, the big thing about UHC is hedged on money.
Yep.
The money that comes in to allow all of these things to be done.
Yeah.
For workers to be paid, for healthcare to be delivered. And I said it's a no-brainer, because here we are saying that there's not enough money to go around and that we don't have enough in terms of contributions. And I said, well, the problem from the contribution is that people don't have that bulk amount of money at once. And that we have been able in the past, and not just in Kenya, around countries, and oh my God, that we've been able in the past to whittle things down to then be able to cater to a group of people who are not able to buy the bulk. So we have 10 shillings oil. We have 10 shillings soap. We have 20 shillings this. You can mimic the same even for your healthcare. That if I don't have 6,000 shillings at once, I have 20 bob a day. You have a 104 billion shilling system. You can't tell me that the 104 billion shilling system cannot then accommodate a part whereby you say 10 to 20 million Kenyans can actually pay a little bit every day and it chalks up to a full amount. And then Dennis said, well, you know, you've been able to figure it out here in 3 minutes. The likelihood that the guys there have figured that out as well, but you don't want it to work.
Yeah.
And
Nobody
that's the
cares.
thing. You don't want it to work.
That's like
Because
another point.
if it worked, I mean, if you did, it would be working. Because there's so many solutions. And that is one where you have a bulk amount. And Yang Nyong'o talked about it many years ago. You widen the tax base, have everybody else paying a little bit, but you widen the tax base so that what you do, you bring more people into the spectrum, and at the same time you have more money that's expendable. So is it possible that there is something that thrives in chaos? This chaos, Kuko is on strike today, KMPD is on strike tomorrow, teachers are on strike the other day. I don't know, we can't pay SHA. People can't, I mean, there's somebody that's thriving in this chaos.
There isn't.
So the possibility that you can see a solution, I mean, it's right there. We don't embrace the situation, or we don't embrace the solution because we don't want the thing to work.
Yeah.
And if you really want to know who is benefiting, it's really easy.
Yeah.
Look at who benefits from strikes.
Private
The
health
private sector.
facilities.
Then the other question that we must ask ourselves,
Who owns them?
very good, who owns these hospitals? And then we must have the difficult question, if you are a public officer, and especially in positions of influence, should you really own hospitals? Should you be doing
You should be
hospital
nowhere near
business?
them.
Yeah.
Nowhere near
When
them.
you're the one who is supposed to manage the public health care? There is something, and I hope when you see the PS, our PS, who is a former comrade of mine, C.S. Oluga, there's something I would like to remind him. When he was on the other side, he kept on saying that our problem is that there are people who do not want the public health system to work. And maybe now that he's in a position of influence, he can be able to answer on how he thinks that can be remedied. But for me, what I would say that we would do as Kenyans, we should force MPs to enact a law that if you're a public officer, your insurance can only take you to a public facility.
Thank you.
We all go there and
Queue together.
we queue together with the patients.
We miss medicine together.
Yes, that no government insurance should pay for private facilities for public officers, so that then the public officers, especially who are concerned with health, can ensure that they make the health work. There is nothing that depresses a health worker than supervising death. Do you know what supervising death is? You are seeing a patient. You know that if I had 1, 2, 3, this patient would survive. But then you know that I don't have this. By the time they get to the other side, they will not make it. So you're basically torn in between. Do I refer them and they die on the way, or do they die here?
You're kidding.
It happens every time. And that is why you see, I saw somebody on social media and saying that medics are drunkards. And I also had a conversation in one of the stations, and they were saying, what did you want to be? And one was saying, I wanted to be a doctor. And the other one told that person that, hey, ungekuwa mlevi. You'd have been... What these people are trying to say is that the community has already observed something, that health workers are abusing substance. But then we must go to the next level and ask ourselves, why is it the health workers? Why not the drivers? Why not the engineers? Why is it the health workers? And it's because of the stress and the depression that comes from this. Because even though you work in that environment that is very stressful and sometimes frustrating, you also do not have counseling and psychology, or those who care for the carers, that they can also be able to debrief and avoid these scenarios.
Peterson, I think together with them, let's just crack the numbers, right? So we have approximately 25 million people who are registered in Nasha, right?
Is that the correct number?
Let's use that.
The last one was 28.
Okay.
Let's use 20. Let's use 25 because I've
Yes.
done math on that, right?
Yes.
And around 6 million are paying.
Is it really?
Let's use that.
Okay. I think
So
it's
you look-
3
point something. So you have the
3.4.
balance, right?
Yes.
You have the balance of individuals who are not paying because it is expensive, 6,000 shillings. Assuming everyone was paying 20 shillings a day, I've just used a number here, 22.
Yeah.
By the end of the month, you'll be having around 9 point something billion. You multiply that times 30, you have 115 billion in 1 month, assuming everyone was paying 20 shillings a day. We're talking about 30 days, you have 115 billion shillings, close to the number that you used to procure the system that is there. If we have 115 billion shillings every month, that is minus those who are paying 2.75%, minus those.
Yeah.
If you use all this chunk and put it together in a healthcare system, one would say healthcare workers would be paid, hospitals would be paid, medicine would be bought, equipment would be there, and that would be having a thriving healthcare system that serves each and every single Mwananchi. Now, we go back to the conversation that when doctors are on strike, the private facilities do benefit. The owners rake in a good chunk of money.
Yeah.
While we have citizens who've gone into these public health facilities because doctors are not working, what would someone do? I will walk into the next pharmacy here or a next hospital in my locale that can help me get relief from the pain that I'm going through. And what do we do with that? Accessing illegal services that people end up dying every day. We do not make that connection. And these things that you talk about, people not appending their signatures, national government, county governments not agreeing despite agreeing with World Bank or the funds that are there, it is because there is no political goodwill to finally sort out our issues. That today, if a member of parliament was going to Kenyatta National Hospital, queuing with a set on the queue, facilities would work.
Yeah.
Mimi nimechoka.
And as you're saying, we really questioned the means testing instrument because it's the main problem here. And the truth of the matter is that SHA has already collapsed.
Peterson, see, it's January. Be nice.
SHA has already collapsed. The reason as to why I say this, I don't want to come here and falsify things just to show that things are rosy. Whatever SHA is collecting and whatever SHA is supposed to pay every month, in every month, if you put the claims on this side and the collections on this side, there is a deficit going up to around 4 billion per month. That is we have claims that are 4 billion more than what we are collecting per month. So which is this miracle that is going to come and ensure that we are able to pay our claims?
It's not even a miracle. Yeah. And that's the problem, Peterson. We look at things as though they're insurmountable challenges. And because nobody's actually ever sat down and said, you know what? And that's why we say maybe they have. That nobody sat down and said, you know what? This thing is the problem. Here is the solution.
Combine.
Marry them.
Our problem is politics.
4 billion shillings,
Yes.
and we've already told you how you can get 100 billion
Yes.
in a month.
Yes.
In a month,
Yes.
by collecting the minimal amount from people. And because of the fact that this communication thing seems to be so difficult, you don't want to tell people what you're doing, so you can't even tell people what to do. You don't want to tell them what you're already doing, so it becomes impossible for you to come later and tell them what to do. And I keep going back to that example of Bwananjoroge when he was at the helm of the central bank.
Yes.
When Kenya was changing its currency, the man was seen every day.
Yes.
For the 3-month period, nobody could say they didn't know that Kenya was changing its currency because he was communicating to people. We have done 1, 2, 3, 4, 5. Now, Kenyans, what we want you to do, bring your old money. Don't stay with this old money in the house, because after this date, we cannot use it anymore. Anybody who came out later and said, November, I've not changed my money. Government didn't even say anything. It was Kenyans now who would tell that person, where were you?
Well, where were you?
Ulikuwa wapi?
Yeah.
They ask that question.
True.
Because they rallied around a common idea. You cannot tell me that the 3.7 million people who are currently contributing to SHA, out of the 55 million people in Kenya, don't even take the remaining. 20 million of them, get them to give you 20 shillings a day.
Yeah.
That 4 billion shillings you're looking for, you will make it times 20.
Very true.
What are we talking about? It is simple. And then engage a communication strategy so that you can have this roll around the country. You mean to tell me if you went everywhere, the people that you have running around during these rallies anyway, rather than hire goons, hire those guys to go and tell people that you can give us your 20 shillings, ma'am, give us your 20 shillings, mzee, so that we can put it somewhere for you. And in a year, you are up to date.
Precisely.
You've paid, and if you have to go to hospital, you don't have to do a harambe. You don't have to sell your you don't have to sell your cow or your chicken.
Yeah.
This is what we are talking about.
It is not that they don't know.
Aye.
When they were doing this, we actually told them that this means testing is only going to deny you these funds you're looking for. And we actually suggested that instead of the means testing, you said the lowest will be 300, yes. Yeah. Allow the former ones to be deducted the 2.75, it's okay. But can you let everybody else just pay 300? History means testing.
Even
Nobody
that,
understands.
Yes, even that, forget the science.
Yes.
Even that, just say, you know what? The amount is 300 shillings.
Yes.
Even with that 300 shillings, you have 5 times the amount of money that you need to cover the deficit and deliver healthcare.
Very true.
Come on.
Yeah.
But do you know why they're not doing that? Politics. If we say that this thing is not working, then politically, they'll say that